Section and say welcome to everyone. We're excited to start our spring series on health informatics research and what's happening out in the community. So today we're very excited to have one of our own, Dr. Morgan Price, and I'm going to let him do his introduction before we begin. Although we are joining from many places, the University of Victoria here, we acknowledge and respect the Lekwungen, the Songhees, Esquimalt peoples on whose territory the university stands, and the Lekwungen and Wasanich peoples on whose historical relationships with the land continue to this day. For those of you who are joining from other places, I encourage you to think for a moment about the land that you are joining from and the relationship you have with it and its people. Okay, on that note, I'm going to go ahead and turn this over to Dr. Price. And I believe you said you're okay with questions to come in
Yes,
while you're going,
absolutely. Yep.
and you and everyone here will notice that there's a Q&A button, and that's how you can enter those questions in. So feel free. Thank you
Yes.
very much.
Great. Well, thank you. And thank you all for coming. I'm looking forward to this and sharing a little bit of work on uh, actually a couple of projects. I'm going to tell a little story around our primary care capacity estimator that we call CAPES and a study, a Delphi study that became an AI study that we call Delphi AI. And when I say we, I'm talking about the Primary Care Innovation Support Unit, or the ISU. And sort of by way of introduction, I was looking at who's attending, and I'm a fairly long time HIMFer at this point. Or are we still called HIMFers? I can't remember. But I see here a couple of folks who we were students together when I was doing my PhD in health information science, and then others who have been students with me as I've been faculty. And so it's great to see all of you in the chat, and definitely look forward to questions. By way of, sort of my introduction, I'm also on the traditional territories of the Lekwungen speaking peoples. So I'm in Victoria and I'm a faculty at UBC, and I get to be here on the island because of the island medical program. So I'm connected to that. I'm a family doctor, but I also have my PhD in health information science. And the work that I've done has been a lot of clinical information systems. And then over the last 8 years or so, I've been running the innovation support unit. And while we're just wrapping up our 8 year cycle, very soon, actually, this is some of the work from that group. And that group has been a little less health information science oriented and much more health systems oriented. And so we've been working on some of the primary care transformation work in the province. But there's been a little bit of information systems work, and that's what I'll sort of share here today. Please do interrupt along the way. I guess popping questions into the Q&A. I've got it up on my screen, and I'll do my best to answer the questions as we go along. Definitely want to be as interactive as we can be for today. So by way of outline, I want to talk a little bit about CAPES and its history. And then as we talked about what this seminar could be about, we thought we could dive into the Delphi study that is part of that project, and then touch on some of the AI work that we did on there. It's a little bit of an older AI study, and I guess in the realm of AI, it's very old. Generative AI. Even these slides that I was working on a couple of days ago were out of date as of yesterday. But I also want to talk about some of the where would I use AI today in research. So CAPES. Where do we start CAPES? In our original grant for the ISU 2017, one of the four things we committed to doing or proposed that we would do would be to create a model that could describe the best fit of a primary care team for different patient panels. And that was one of only four things, and it maybe seemed a bit ambitious. And after we built it, we realized it was ridiculously ambitious. So version one was a spreadsheet-based tool that was, I would say, it's precise but not accurate, and it was never released. I got people were very interested in it, but I realized that it was recommending 3.72 FTEs of nurse in a team, but I didn't know if that was plus or minus 10. So I really didn't feel confident in using the numbers, and I worried that it might be used for policy. So we parked that and worked on some of the other areas of the innovation support unit. And a few years later, the BC Ministry of Health said, have you ever thought about how to model teams and estimate the capacity of those teams. And so it gave us an opportunity to dust it off and revisit some of the evidence. And we started building a version 2. And we took quite a different tact on this. And instead of doing anything with a spreadsheet, we did a simulation model. And so here's the UI for that. And it simulates the visit demand over a year for a panel of patients using a few very vague and simple criteria in the population model, and then matches that to the visit capacity of family physicians, nurse practitioners, and nurses. And there's a few sliders that we can adjust based on amount of shared care and complexity of patients. And then instead of predicting the optimal fit of a team, it tries to predict the percentage of care that's being met. And so there's a certain amount of outflows and those sorts of things over that simulation. And then each role has different priorities. So family physicians will have a certain scope of practice and they're able to see most of primary care. Nurses have a different scope of practice, and so they're able to see different parts of primary care. So you can see on the graphs in the middle, there's sort of the primary care providers and the team and the unmet needs in the graphs. And we're able to, in real time, adjust these and we've run a series of workshops using this tool to help healthcare planners look at service plans for primary care networks or for different communities, different regions, and different clinics, and help them reason about how the proposal fits what we predict the demand might be. And in those workshops, it's been a great way to use this as an education tool for healthcare planners, and as one data point to think about, what should the team look like. Certainly isn't giving us the definitive answer, but it's been nice to be able to use it as a collection of an option to look at things. And then we can also in real time say, well, what happens if we can't hire 2 doctors, but we can hire 1 nurse practitioner, 1.5 FTEs of RN? What does that look like? And we can in real time adjust those. So this was a great advance over the blurred out spreadsheet that no one's allowed to see. But the question then was very quickly, that's great, but what about social workers and pharmacists? And so we wanted to expand our clinical professions in this group. And so here's a newer version, and spoiler is that we did develop this version, and then this is the one that's in use right now. But we added in these additional 6 professions. The problem that we weren't in the first version because we had an evidence gap. We really didn't know, I didn't really have any solid evidence in primary care that was usable in a way to fill the model around scopes of practice for these different professions. I've worked with them. I've worked for over 20 years in primary care and team-based settings, and I've worked with all but physician assistants on this list in different capacities in team settings. And I don't have anything at all against physician assistants. They just haven't been regulated to BC, so I haven't had the opportunity. But trying to get data that allowed us to figure out what percentage of primary care can be shared was something that we were missing. And that drove us to a CIHR study. And that's the evidence that we needed to develop. And that became our Delphi study. And so we were lucky in getting our CIHR grant. And this was about 2.5 years ago now. And we wanted to help build that evidence base for the clinical capacity with different providers. And given how the CAPES model works, it's kind of backwards. So it's not just about what is the scope of practice of a social worker, but what percentage of primary care visits can be shared with a social worker. So it's a bit of a tricky question and it's hard to get data on. And so we opted for the Delphi, which felt like it was a reasonable first step in this trajectory. It's certainly not the definitive step for us, but it was the first step. And this is sort of the outline of the study. And we actually ran 7 different Delphi. We did for the 6 allied health, and then we decided to do one for registered nurses as well. Felt as we were here, we might as well complete the sort of the grouping. And we ran these pan-Canadian sequentially over the course of about a year, uh, running multiple rounds. And then out of those, we both gathered some of the information that we needed, as well as information for our ministry colleagues, and that which was helpful for them. I will. I'll just walk through that. I was going to say, show of hands, who knows the Delphi method? But I don't know if I won't be able to see hands here, so I'm going to walk through it. If it's something you're familiar with, I'll be quick. But I just wanted to walk through the Delphi method because it's relevant for the next part as well.
They can raise their hands electronically, Morgan, just a
Oh,
heads up.
okay.
Yeah.
Okay, I just can't. Oh, there we go. Yes. So without naming names, I'm not at all surprised by the people who are putting their hands up. Those of you I know. So the modified Delphi, I think we all do a slightly different version of this, but it's essentially finding different experts and getting them to come to a level of consensus around a particular question or set of questions. And in this study, I'm going to talk about just one of them as an example. But we recruited a number of experts. In this case, let's talk about them from the registered nurse perspective. So most of our experts were registered nurses who worked in primary care. There were some primary care providers, so nurse practitioners and family doctors who have worked with registered nurses, and also policy or researchers who have done work in that field of scope of practice of nursing in primary care, so that they could inform the questions from their perspective. And then in the Delphi process, you ask the same question independently of all the experts, and then you get their answers back independently, and then you summarize those answers. And for those of you who aren't familiar with the Delphi process, you're looking at this and going, "That's just a survey, Morgan." You survey some people, get their answers, and then you summarize the results, and that's true. But in a Delphi, that's just round one. And then you repeat the process by taking the summary information, the answers that came out of it, the synthesized answers, and bring those back to the experts and get their feedback. So you're able to do some internal validation through the Delphi to eventually reach consensus. And that's essentially the process we did times 7. So we took our group and we had different experts, of course. If when we were talking about social workers, we had more social workers, and then we had OT, we had occupational therapists, etc. And we did these 7, which I've mentioned already. We did ask a number of questions in the Delphi that helped fill the model up with the CAPES model, particularly things like daily visit capacity, what percentage of acute primary care is in scope, what percentage of chronic primary care is in scope for the profession, what percentage of preventive care was in scope. What was the delegation model? What kind of articulation work needed to happen between the providers? How much time would it take for the primary care provider per day to do that teamwork with the other person, so that we could use those data in the model to drive that new version 3 of CAPES. And we also wanted to get examples of scope of practice that would be educational for non-experts to understand what would be sort of some of the top things that profession can do in primary care. And that allowed us to create a series of briefing notes for our colleagues at the ministry that included some literature findings, some of the results from the study, some of the quantitative data, but as well as the list of shareable primary care visits. So here you see on screen one of the pages of the policy brief, and I'll draw your eyes to the right-hand side with the example of shareable primary care visits. So this would be some of the things that are in scope for a registered nurse that is primary care relevant, that could be shared and should be shared with a nurse that's in your team. And those are according to our Delphi. our Delphi experts. I'm just going to pause and have a quick look for any open questions, and there aren't any because I'm going to shift gears. So if there are questions about the Delphi, I'm happy to take those. And if not, I will move to the next part of this. Okay. So around this time, 2023, large language models were becoming a bit of a thing, and they were becoming interesting, and we had the Chat GPT moment, and so we started asking ourselves a question. So how well could a large language model answer one of our Delphi questions? This does feel like it might be a little bit not out of date, but older now. But it was really an interesting thing to think about at the time. And for those of you who know me, once I get a clever name or acronym in my head, I think I have to do the project. So once we thought Delphi AI was a thing, we had to make it a reality. So we decided to simulate a Delphi study using AI agents. And this was back in 2023. So this is pre-reasoning models. We took one of our original questions from the Delphi study, and that was what primary care visits can be delegated to a registered nurse. And as we had already finished that, we did the RN Delphi first. We had those data already. And then we had two questions for the study. And before I'm gonna build some suspense here. Before I tell you what the two questions were, I'm just looking and I see we do have a question. So is CAPES predictive based on the consensus models? So yes, it is based on the consensus models in part. There's other published evidence that we had originally as well that was incorporated into it from people like Justin Porter from Boston. And then we have been doing some validation, I would say sort of small v validation. Unfortunately, we weren't successful with our next grant, which was to do the validation of the work in a more robust way, but we have been doing some validation with clinics as we go along. But definitely it's still an open question to do more of that. So thank you for that question. So coming back to Delphi AI, the two questions we had was, is it possible in 2023 to simulate a Delphi study using AI? And then how well does it work? So was it physically possible? Did it kind of make sense? And then how well does the AI answer the question? So if we go back to that kind of process of a Delphi where we have our experts individually answering questions and summarizing and then processing the results through, could we run all that through and create some software? And so we created 10 agents that matched some of the characteristics of our human experts. We asked them the same question and we got answers that made sense. Not surprisingly, I think in 2026, our human experts compared to our AI experts, the AI experts tended to be a little bit more verbose in their answers, which actually was helpful when we were trying to understand sort of what was coming out of these systems. We also used a chain of thought reasoning in our prompting structure, which is now really baked into reasoning models. But at the time it wasn't, and we had to sort of recreate that in our system. But the answers that came out, as I said, they were reasonably sensical, and we were able to continue with our process and summarize the answers into a coherent subset. And then we were able to give those answers back to the same AI agents and get them to confirm or deny whether they felt those elements are in scope or not. And that gave us our results. So we were able to answer that first question. Absolutely, we could simulate an AI Delphi. The answers, as I said, seemed reasonable. And yes, so the question is, did you also use the AI to help with the summary component? The answer is yes and no, because we wanted to see how well it summarized. So we did the summary independently and then compared it to what an AI agent would be able to do to summarize it. And again, it was similar. That's great. We're getting questions. So I'm sorry. I'm going to jump over to the questions here for a bit. Okay. So did the AI get prompts that incorporated domain knowledge? So part of our question was, how well would this work with the existing models without a retrieval augmented generation system, without specific prompting with the answers in it, just based on what their knowledge was. So all we built was a chain of thought prompting process and the harness to do this with multiple agents on multiple questions. So we didn't incorporate explicit knowledge from scope of practice documents, etc. It was based purely on the model's built-in training knowledge. And at this point in time, they also weren't searching the web on their own. So what we did is we gave them the persona of different people. You are an expert in primary care nursing and have had 20 years experience, blah blah blah, like that sort of piece, but not the actual scope of practice documents or anything like that. We did give them a little bit of character. So some of them were perhaps a little bit more conservative in the description of who they were. Some of them were a bit more keen on team-based care, but they were all asked to think about the scope of practice and describe their rationale before they gave an answer. So I hope that answers the question. So yeah, so they were essentially matched to the nursing roles in the prompt, the physician roles in the prompt were matched to our original Delphi. And then to that other question, did they help with the summary? Yes. And I said yes and no. What we also did was to compare quality. We took the summary from our human experts. So this was a list of about 40 summarized reasons for visit: diabetes education, sexually transmitted infection testing, medication reconciliation, etc. So 40 of them that were from round one of our human experts. And we inserted it into the Delphi AI software midstream and ran it again. So ran the round two a second time. And that allowed us to then really look at this second round step of validation. And we were able to then expressly compare the results from the human round two and the AI expert or AI agent round two. And essentially, how this worked in the study was for each proposed reason for visit that was in the summary, those 40, decide whether it's in scope or not, and then whether it should be included in shared care or excluded, and then give your rationale. And in fact, we actually did it the opposite direction. So we said, give your rationale and then make your decision. So that supports that chain of thought. And we were able to then compare the results between the humans after round two and the AI experts after round two. And that answers our second question. So we did this originally with GPT-4, and then in the fall of 2024, I redid the study with GPT-4o, just out of curiosity. So I'm going to use those data here. And I saw a question pop up, but I think it's gone. So what we had was a 90% agreement. The AI agents agreed with the human experts on 36 out of the 40 different visits from that second round. It was a little bit lower. I think it was 83, 84% when we were using ChatGPT or GPT-4. Sorry, we did not use ChatGPT. We were using the API in the back end. But with 4.0, it increased to 90%. I have rerun some of this now, and I haven't run the full study, but it stays close to that. Of interest, the other metrics we looked at was time to complete. And so this took slightly less than 33.5 seconds to complete. Compared to the human experts, it was a significant time savings because, as you can imagine, running through a round takes several weeks of reminder emails, etc., and to have be completed, as opposed to these agents, which were very fast to run and all ran in parallel. And the round two results cost slightly less than $1.20. Now that's US dollars, so I don't want to exaggerate the savings, but it was still significantly less than the honorarium paid to the human experts. So very interesting numbers at the end of this, and I think it might be. I hope it's interesting to look at some of the differences, those 4 visits that were in disagreement. So here are the 4. Overall, the AI agents were a little bit more conservative than the human experts. Although med reconciliation, the AI agents, the cutoff was greater than 85%, agreed that it should be in scope. For the human experts, it was less than 85%, so it was not agreed to in the Delphi. All the rest of them, the AI agents, there were a few holdouts around medical forms, cryotherapy, and STI treatment, where the human experts felt that these were things that could all be potentially shared. So I'm going to go into one of these a little bit, just to show what the answer was from one of our agents. And this is from Ruth. The persona Ruth was an RN. We cleverly named them all with the first initial of, so all the R's were registered nurses. And we asked Ruth to describe the task, then provide the rationale, and then make a decision. And that process provided the sort of the thinking time required before we had reasoning models. So it's that chain of thought. And I want to highlight a little bit of this. So this was quite surprising at the time. So here's one of the sentences. So, however, the prescribing of medications typically falls outside of the scope of practice for registered nurses in Canada. And that's true. Unless they have additional prescribing authority, which is also true, and that does vary by province. So it's a surprisingly nuanced answer. So it wasn't just meds aren't in scope. It was much more specific about it. And then in this case, Ruth opted to say, because that's limited to only those with this additional training in certain provinces, this is a visit that cannot be fully delegated. So then they excluded STI treatment. So particularly at the time, surprisingly nuanced answer. And this was consistent. And I don't want to say that the human experts were any less nuanced, but they were less verbose. So it was sometimes we didn't have the data to look at the rationale when we were doing the analysis, but we almost always had the rationale from our AI agent counterparts. And so a fascinating kind of exploration into what we could do with this, again, in 2023, repeated again in 2024, before there were reasoning models readily available. So what I use AI for now, um, like I said, some of the things I was going to say perhaps even changed yesterday. While I was seeing patients, two new models got dropped and released um, yeah, yesterday morning, so which is hard to keep track of these things. But I think, well, let me put the given out there first. So organizational policies, follow those. There's lots of concerns around privacy and security. So make sure that you're aware of what that is. Make sure you're doing things safely and from a privacy perspective and security perspective, you are doing all the good and right things to do. Um, where would I start to use this in different studies like a Delphi study and other perhaps more clinically oriented research? And so I would exclude researching AI, like the Delphi AI, where we were just testing the capabilities. So excluding that, where would I go? Um, I do think there's a piece of survey selection and question development that is something that's relatively safe to explore, and you can get some really interesting feedback these days from models. Uh, you're not disclosing any data, answers from actual participants. This is just purely which of these surveys best fits and why. Give me some rationale, and then you're the ultimate judge of that. But I think it can give you a different view. One of the agents that I have built lately is called Grumpy, and I definitely ask Grumpy for some serious critique on some of the ideas that I have. Grumpy is not very sycophantic, as you might imagine. One of the risks of some of these AI models is they can get very, very enthusiastic with anything you suggest, or maybe not anything you suggest, but sometimes they've gotten very enthusiastic. So prompting them correctly and giving them the right persona and information to be critical is important. So Grumpy fills that role for me, and can help with some of these selections and the pros and cons and trade-offs. I think another place in this space, if you're developing your own survey questions, um, is to pilot the survey questions. I don't know how many people have tried this yet, but how often it's best practice to pilot questions with your potential audience, but it can be hard to do that, especially if recruitment is already a challenge, and then you're asking people to please answer this just for practice. Um, this could be a pre-step to that, where you can create personas. You can give them uh, different knowledge bases or gaps in knowledge, and get them to answer the questions. It's quite illuminating to see that the questions are less clear than you think if you've been writing your own surveys up. And this is a very inexpensive way to do that. So that's one area where I would use these tools today. I think generating draft materials to test, simulation data, that sort of thing, synthetic data, absolutely. These tools are getting amazing at that. I need a spreadsheet. Give me a spreadsheet full of data with answers to these questions, and here's the spec for each question. I want a population size of 20,000 people, and this is roughly what I want. Make it realistic. Then you can use that in your testing for all sorts of things. That is really powerful, and you're not disclosing any information. I think there's spots with the privacy perspective where Delphi can accelerate method. Uh, Obviously the overall Delphi AI that I talked about round two there, how much time that saved. But I think there's other spots. Um, in an overall Delphi, we created some information to prime the pump, if you will, with our experts. That's a great place for AI to help start. You need to obviously vet the materials and all that, but you could move the Delphi process one round further forward by using the first part of the Delphi AI to create some of those lists. and then use your experts to purely validate. You can then have more experts and they can do it quicker than if they were following all the rounds separately. So I think there's a modified Delphi there that is something that I would consider doing again. Synthesis and analysis. I'm not sure. I'm hesitant here a little bit. Part of it is that I think that the models that are the best at synthesis are not the ones that many of us as researchers have access to. They're cloud hosted frontier models, and then we should not be sending our data up there. So you're going to run local models. Running a high-powered local model requires some high-powered equipment, which is not what's sort of within reach of many people. If you do have it, then I think you could definitely explore some of the models. But you really need to know what the synthesis is and how it's being done and validate it. Ultimately, we're responsible for what we're producing, and so we need to be very clear about that. The other part of it is and I'm sure this will change, but it's the replicability of the synthesis. Similarly with, say, a systematic review, there's several products that'll do systematic reviews. How it's defined in such a way that it can be replicated is a question, and that's very important in science. So I do think there's an it depends here. I think for those of you who are not in the research space in the audience, there's a real advantage here for some of the sufficiently rigorous analysis, all the same caveats that I just said, but there's a slightly different, perhaps sort of level that a bar that you need to meet, still acknowledging you shouldn't be sending up private data. So that synthesis is one that I'm still sort of on the fence on. And I'd certainly be interested in other people's ideas about where, in these kinds of studies, this kind of work, you're either using these tools, large language models, or have thought about it and had questions, and maybe that can trigger some dialogue we have in the last 15 or 20 minutes. And that kind of wraps up my slides. So I'll just say thank you here, and I'll turn off the screen sharing so that so we can chat if there's questions.